Bills back. The gentlelady from North Carolina, Mrs. Foxx, is now recognized for her questions.
Thank you, Madam Chairman, and I want to thank our witnesses for coming today. But I have to say that listening to this last interchange, there are some people on this committee and some of our witnesses who live in a never, never land, a never, never land. Ms. Turner, today we've heard a lot about government-run health care, such as Medicare for All, but we've not heard much about the quality of care. This is not surprising, though. I cannot think of one thing the government does that is both affordable and of high quality. What would Medicare for All do to employer-sponsored insurance, and how would this affect the 155 million Americans currently enrolled in employer-sponsored coverage, something that Americans overwhelmingly support?
Well, the Medicare for All would abolish employer-based health coverage and all other current health care programs so that we would all be under one single plan. And you see employers trying so hard to innovate, providing wellness programs. Walmart, before the Affordable Care Act was implemented, had computer rooms to help their employees tailor a plan that worked best for them. That's the kind of innovation that we would lose, the kind of patient focus, the kind of energy from the private sector that leads to innovation.
Okay. How would Medicare for All affect the nearly 64 million seniors who are currently on Medicare? Would they receive better coverage?
64 million seniors and disabled patients on Medicare, 26 million of them have chosen Medicare Advantage private plans. That shows that they believe that there's more value to having a private plan that can manage their care. They can pick the plan that provides the best network in their area. So they are, and some we believe could be focused care. If you have diabetes or heart disease, you will get the specialist in that care. So I think that there would be a lot of innovation lost, and I don't think seniors would be nearly as happy as they are now.
Yeah, as I understand it, our friends on the other side of the aisle want to do away with Medicare Advantage and the kinds of things you've described. Also under Medicare for All or another universal health care system, would Americans have wait times to seek care that are similar to those in Canada and the UK?
Absolutely, because there are lots of different ways for people to pay for systems, and one of them is in care that they don't get, and oftentimes they don't even know the care that they're not getting. I talked with a physician from the UK, and he saw both private patients as well as those on the National Health Service plan. And he said, I can't even tell my public patients about new medications that would be better for them because it's not covered under the system. Patients who are going to have to wait for 2 years to get a knee replacement surgery, pay out of pocket if they can to go to the Mayo Clinic if they live in Canada or someplace else. So patients pay in other ways, especially those most in need of serious medical care.
Thank you, Ms. Turner. Another question. The Mercatus Center calculated the cost of Medicare for All and found that under the best case scenario, it would increase federal budget commitments by $32.6 trillion over the first 10 years of implementation. $32.6 trillion is triple what the federal government spends on our defense and domestic discretionary programs over 10 years. Even doubling the corporate income tax could not cover that. Since our government is consistently overspending and running large deficits each year, is a massive new government spending program like Medicare for All financially feasible or sustainable?
It's really hard to see how that could work. As I said in my testimony, that Colorado, Vermont, and most recently California have tried to figure out how they could do, just on a state basis, a single-payer system. In California, even California saw the price tag of $450 billion a year, and they said that's really not something we can afford.
Thanks. And my last question, what lessons can we learn from the implementation of Affordable Care Act or Obamacare, and how should that inform our expectations for further government involvement in health care?
Running a top-down system is really difficult, especially from Washington in a country as diverse as this one is. And one of the reasons there have been so many changes to the ACA is because some things worked for some states and others didn't work for other states and for different sectors of the economy. You need to have local control, bottom-up decision-making, not top-down decision-making that could have the same catastrophic effect as healthcare.gov did.
The gentlelady yields back